Here's a quick look at today's program, and we'll share more information about this in a few moments. Throughout today's session, we invite you to submit your questions for our presenters using the Q&A panel on your screen. You'll notice there's a box you can check, send your question anonymously. So if you wish to do that, we invite you to check that box. Today's webinar is being recorded and a captioned version will be made available on the library's website in the coming weeks. Here's some information about that, which we'll share again before we wrap up today. If you have a question that is not answered during today's webinar, we invite you to submit it to the Library of Congress Ask a Librarian function, and we'll share that link before the end of today's session as well. So with that said, to get us started, please welcome the Chief Medical Officer at the Library of Congress, Dr. Sandra Charles.
And good morning to everyone, and particularly to our speakers today who have come to us with great sacrifice in their time. I'd like to welcome you to this, our fourth in a series on COVID-19. The series is co-sponsored by the Science, Business, and Technology Division and the Health Services Division of the Library of Congress. A key objective for us is to connect our staff, visitors, and the general public with these expert clinicians and scientists who have important knowledge that guide us in the right direction, enhances health literacy, and a more productive work environment, even while promoting the library's mission of service to Congress and the American people. In early 2020, when this infection emerged, it was thought to be a respiratory infection. However, as the months have gone by and the pandemic took hold, the virus has shown itself to have a variety of manifestations affecting multiple organ systems. The brain has been affected not just in the early symptoms of acute stages of the illness, but over time after the acute phases. COVID-19 survivors have been shown to face a remarkably increased risk of developing psychiatric or neurologic disorders immediately and even 6 months after they contract the virus. Some of the research has shown impairment of the lining of blood vessels and resulting blockage and neurologic impairments. Symptoms ranged from loss of smell and taste to strokes to brain fog. In addition to these neurologic findings, there are also psychiatric deficiencies with worsening of depression, anxiety, and new onset of other disorders, including suicide. Today's presentation will cover some of these COVID-associated brain disturbances and give insight into their genesis. We are most fortunate to be able to hear from preeminent scientists personally involved with the research and recipients of science and medicine's most prestigious recognition. I will now turn the floor over to my distinguished colleague, co-sponsor, Dr. Tomoko Steen, to introduce our speakers. Thank you.
Thank you, Dr. Charles. Next slide, please. We have two distinguished speakers today, and wonderful to have Professor Ikegawa joining us after midnight in Japan time. Professor Masaya Ikegawa is a professor of genomics and biomedical functions at Doshisha University. He has done the PhD under really prominent scientist and Nobel laureate, Honjo Tasuku, and he actually started this immunotherapy of the cancer treatment and so on. And also he's a classmate of another Nobel laureate, Professor Yamanaka Shunya. So he himself, Professor Ikegawa himself, is really working cutting edge science in the neuroscience area. His topic is cognitive and neuropsychiatric impact of COVID-19. We have also another prominent speaker, Professor Dorian Lamis. He's assistant professor and clinical psychologist, and he's at the Department of Psychiatry and Behavioral Sciences at Emory University. And he has done PhD from the University of South Carolina, and he has also license for as a board certified license as a clinical psychologist. He has published more than 150 peer-reviewed papers, and the most recent book, he's one of the authors. It's called Advancing the Science of Suicidal Behavior, which is really amazing book. I actually, because of this occasion, I purchased it and read it. It's a wonderful study of looking at the suicide from science. And his topic is suicide prevention in the COVID-19 era. So let's start with Professor Ikigawa. This is floor is yours, and thank you so much for doing this.
Okay, thank you for kind introduction, Professor Steen Tomoko Sensei. And I'm Masa Ikegawa from Kyoto, Japan. Now, Japan is in midnight and also in the midst of the COVID-19 pandemic. So today I'm very honored to be here to share some important topics like COVID-19 and the brain. So shall we start? Already many medical articles are published on neurological manifestations of COVID-19, and these are very immediate early symptoms of the people. The popular symptoms are headaches, myalgia, muscle pain, insomnia, chronic fatigue, and loss of taste and smell. The last one, loss of taste and smell, is very specific symptom for this virus. And later on, we will talk about the significance of this symptom in the development of other neurological diseases like Alzheimer's disease or Parkinson's diseases. So next slide, please. Okay, first, let me introduce some entry mechanism of the virus. So first entry mechanism was through the nose. First, virus entered into the human nostril, and then stick to the some cells who expressing some receptors for the odorants or some virus. So the first entry system was through the nose, and the second was, as you all know, this virus first infected the respiratory system like lung. So some scientists are thinking that the vagus nerve who innervated the lung retrogradially, the virus entered into the brain. So these two hypotheses must be validated through some scientific evidence. But now these are the hypotheses. Next, please. Next slide, please. Okay. First, we think about the brain was protected from the outside, like virus or some toxicants. In my medical school days, teachers are teaching us that the brain was completely protected from the outside because there is no lymphatic vessel in the brain. The famous textbook of the Gray's Anatomy, it is definitely written that there is no lymphatic vessels in the brain. But more than 200 years ago, some Italian anatomist, Paulo had a very nice eye who published his own anatomy book. And in his book, on the left panel, he describes the lymphatic system in the brain. But this important finding was ignored for many, many years. And next slide, please. In a very recently, 2015, Kipnis, an American scientist, found and revisited that the brain lymphatic system is really existing. So in this left panels, you see in the here is the surface of the brain. In the surface of the brain was the subarachnoid space, was equipped with some fluid. And it is very difficult to find that the lymphatic vessels in the dura. So they proved that the brain is also under the influence of the lymphatic system of the human system. So again, this finding was ignored for more than 200 years. So now we are knowing that the neuron and nervous system and the immunological systems are tightly collaborated in this situation. Next slide, please. Okay, back to the COVID-19 and loss of smell. First, SARS-CoV-2 virus entered from the nostril to human epithelium of the nose. And once virus was stick to this epithelium, maybe these tissues were damaged and then go into the brain through the bone. So this is one strong evidence that the virus neuroinvasion really occurred in this area. Next slide, please. Some scientists proved with a fine technique using the immunohistochemistry. In the red-colored cells, there it is COVID-19 virus component. It was shown in the red color. And the green color or the blue color was showing some normal epithelium cells. So this is a real proof that the virus enters through this epithelium. Next slide, please. And also, once smell was disturbed, also the taste must be disturbed. This figure was explaining this mechanism. As I explained, also nasal route from the nose to the epithelium, and also the food makes some vapor or flavor from the retronasal route. So these two informations are integrated into the same pathway. So loss of smell and taste occurred simultaneously. Next slide, please. As everybody knows that people may lose smell sensation with age. In this graph, in the x-axis, the years of the age. So the y-axis showing the smelling ability. So when people aging, then the smelling ability was decreased. But in Parkinson disease patients, the decline was more prominent than the healthy control people. Sometimes these olfactory dysfunction shown in Parkinson disease was sometimes used as an early marker of the disease development. So from now, we must think about the effect of the COVID-19 smell loss. So in this order finding, we must add on the effect of the COVID-19's virus smell of loss. So next slide, please. Okay, after immediate and early symptoms of the COVID-19, soon we must think about some psychological manifestation like depressive symptom, PTSD, anxiety, difficulties in concentration, and memory deficits. And later, these two symptoms are known now, the brain fog. Next slide, please. So in other words, long COVID issue and brain fog is a fatigue and the lack of ability to concentrate and can severely affect memory and cognition. these symptoms are not specific to COVID-19, but in the historical description, influenza pandemic in 18 in Russia and Spanish flu pandemic 19 and other some infectious diseases, sometimes brain fog phenomena was observed. But we must accurately know what is similar and what isn't similar in this pandemic. Next slide, please. Already, to start seeing, but many patients are dying with COVID-19, and already neuropathologists are diagnosing with the brain of the dead persons. So these diagnosed diseases like encephalopathy, ischemic stroke. It's a kind of stroke which is concerned with vascular problem, and peripheral nerve deficiency, Guillain-Barré syndrome, and also the Bell's palsy, and intracerebral hemorrhage. It's a vascular problem, and encephalitis, and acute disseminated encephalomyelitis. This diagnosis situation was mainly occurred in the white matter of the brain. Next slide, please. We are studying on the mechanism or some therapeutic strategy for the multiple sclerosis in Japan. In comparison with Western people, or we Asian or Japanese people are less complaints of this diseases. You see in the MRI, in the white matter of the MS patient's brain, some arrow shows that some demyelinated white regions. And in the middle of this panel, you see some loss of the neuron, a large mass of the loss in neuron in the white matter of the brain. On the rightward, the spinal cord, long spinal cord region was also observed. So this kind of autoimmune disease occurred in white matter. Next slide, please. And back to COVID-19, Harvard group has already published some paper, and in the panel A, you see the patients who died of COVID-19. In the white matter, there is some small bleeding. In panel C, you see the red blood cells in the brain. And also, you see the tiny little immune cells surrounding the vascular in panel D. And in panel B, here is some signs of the hypoxemia the patient was suffering. Next slide, please. Okay. So in comparison with Alzheimer's disease pathology, this senile plaque composed of small tiny peptides and the neurofilament tangles within a neuron is mainly occurred in the gray matter of the people. Next slide, please. So in a cartoon, this amyloid deposition typical to Alzheimer's disease affects the main vasculature in the gray matter, and also it affects white matter, but detailed mechanism or the details the phenomena in white matter was not obvious for the moment. Because white matter is surrounded by the like seas. So gray matter is very typical region we can diagnose as Alzheimer's disease. So next slide, please. Go back to the lymphatic system in the brain. Yeah, thank you. This slide is right. do you remember that I talk about the lymphatic system in the brain? In the left panel, in young healthy brain, there is some solid functional or lymphatics in the dura. So there is a circulation of the molecules or some maybe virus inside the brain. So this lymphatics is a very nice pipe to working very well. On the right panel, some dysfunctional meningeal lymphatics was typical to the aged brain or also some diseased brain. So this is one explanation that the Alzheimer's disease brain accumulates some amyloid or, or in the parenchyma. So next slide, please. So this is some chronological aspects of Alzheimer's diseases. People start complaining, seeing a plaque in his 50s, and then 10 to 15 years later, in his 60s to 70s, neurofilament tangles was observed in the gray matter of the patients. Then these two signs completed gradually. Some clinical symptoms like mild cognitive impairment or dementia was developing. But as I mentioned, there is no detailed analysis on the before 50 or before 40. Maybe in the white matter, what happened in the white matter of the patients. And also, as I mentioned in the Parkinson disease issue, from now we must think about the effect of the COVID-19 on this schema. That means in the white matter, there are so many microbleeding or some vascular trouble, and then what happened? And also now in his 50s, 60s, 70s, what happened to this ongoing Alzheimer's disease pathology? So next slide, please. So this is my last slide. Now we can summarize the COVID-19 and the brain issue. Maybe it's coming from the direct viral infection through nose or the other way. And it causes loss of smell and taste. And this is a serious problem, considering that the Parkinson or Alzheimer's disease also affect the smell and taste system. And also, this infection is severe systemic inflammation, and sometimes new inflammation also occurred. And combined with intravascular coagulation of the blood in the white matter, maybe this immediate early to long COVID situation may affect in the latter of their age, neurodegeneration may be affected. So we should precisely find out what the future outcomes of Alzheimer's disease from now, considering this background. So thank you for your attention.
Thank you so much, Dr. Ikegawa. If you have any questions, please just write in during the lecture, and we will read at the end of presentations. So next speaker is, next speaker is Professor Dorian Lamis, and he's going to talk about the suicide and COVID.
Well, thank you, Dr. Steen and the Library of Congress for inviting me to speak to you all today on this important topic of suicide prevention in the COVID-19 era. Next slide, please. So here, briefly, my personal and professional disclosures and conflicts of interest. Next slide. So overall, close to 800,000 people die by suicide each year globally. And the suicide rate is 10.5 per 100,000 people. It is the second leading cause of death for 15 to 29-year-olds and accounts for 8.5% of all deaths around the world. And the most common method of suicide globally is ingestion of pesticides, hanging, and firearms. And in the US, it's by far firearms. Next slide, please. So specifically in the US, in the year we have the latest complete data is 2019, 47,511 Americans died by suicide. And that rate is 13.93 per 100,000. And this suicide deaths are 3 times as high as homicide deaths. And in 2019 was actually the first time that the overall rates declined in over a decade, and they declined by 2.1%. In fact, from 1999 through 2019, the age-adjusted suicide rate increased 33%. So from 10.5 in 1999 to 13.93 in 2019. And 130 people die by suicide each day, which equates to about 1 suicide death each or every 11 minutes. Next slide, please. So this is a chart of the 10 leading causes of death in the United States, again from 2019. And suicide is the 10th leading cause for all ages, but if you look at the age breakdown, you see, as I mentioned, 10 to 35-year-olds it's the 2nd leading cause of death, and the 4th leading cause of death for 35 to 44-year-olds, 5th leading cause of death for 45 to 54-year-olds, and then it gets kind of moves down the line, but that's in older adults. They're usually dying from more physical ailments and illnesses. But as you see, the unintentional injury for the younger adults and teens is the #1 cause of death. Next slide, please. So in the most recent data that we have, a study that was published a few months ago in The Lancet, Jane Perkis and her colleagues compared data from the pre-COVID-19 period to post-COVID-19 periods in 21 countries. That included 16 high-income countries and 5 lower to middle-income countries. So the dates that they looked at, the pre-COVID dates were January 1st, 2019 to April 1st, 2020, and the post-COVID dates were April 1st to July 31st, 2020. And what they found was that the results indicated that there was no evidence of a significant increase in the risk of suicide during these first 4 months of the pandemic in any country. And moreover, there was statistical evidence of a decrease in suicide compared with the expected number in 12 of the 21 countries studied. So these data on suicide during the early months of the COVID-19 pandemic are actually consistent with the observation that in times of national crisis, it could be associated with a protective effect against suicide. And this is perhaps due to a greater social cohesion and connectedness. And this same effect of a decrease in suicides has been found in other national disasters and crises, such as after Hurricane Katrina and 9/11. So, I mean, this is somewhat unexpected, but at the same time, we've seen this in previous crises. Next slide. So similarly, in the US, the data that we have, which was again recently published, provisional estimates from the national mortality data from January to June of 2020 showed that the COVID-19 pandemic substantially affected deaths across the board in 2020. But specifically, suicide deaths declined 5.6% from 47,511 to 44,834. So, and as you can see, under the 2020 column, COVID-19 is now the 3rd leading cause of death. So this is supports the global data that I just showed. And in addition to this pulling together hypothesis that I mentioned following a pandemic, an alternative hypothesis or explanation for the decrease in suicide is that of competing risks. So that is that many of the people who would have died by suicide at any other year may have died from COVID in 2020, and reducing the number of observed suicides in this year. And in support of this, that COVID fatalities are most common in older adults who are the largest group who also die by suicide and COVID. So this is one explanation. Another explanation, as can be seen here, is there has been a dramatic increase in unintentional injuries, nearly 20,000 increase from 2019 to 2020. So it's possible that that more of the overdoses were actually misclassified suicides. And there's some other explanations too, but there's caution that needs to be had in these early data that are coming out that suicide has decreased. So although there's this initial snapshot of decreasing suicide appears to be promising, we really need to remain vigilant for a possible delayed increase in suicide as a result of this pandemic, as there may be a lagging indicator of psychological and psychosocial difficulties coming. Next slide, please. So again, despite the seemingly decreased suicide rate during the pandemic from the now available data, there are several common psychological reactions to COVID that have been documented since the pandemic began. And these include anxiety, worry, loneliness, social isolation, depression, hopelessness, frustration, irritability, and anger, helplessness and powerlessness, alcohol and substance abuse. We've seen a spike in that since the pandemic began. Disruption in sleep and appetite, as well as PTSD-like symptoms. And all of these reactions are associated with an increased suicide risk. So again, we have to continue to monitor these reactions and symptoms. Next slide. So in fact, both in the United States and the UK, symptoms of depression and anxiety have increased. So specifically in the UK, symptoms of depression have doubled prior to the pandemic to June of 2020. And in the US, almost quadrupled pre-pandemic to post-pandemic. So again, these psychiatric symptoms are increasing due to the pandemic. Next slide. So 70% of Americans also report that the economy and financial stressors are a significant source of stress and have been causing some psychological symptoms and disorders. So compared to 69% of people who reported this in the 2008 recession and 46% just in 2019 pre-pandemic. So these economic and financial stressors are also could cause suicide, an increase in suicide risk. Specifically, people of color are experiencing a disproportionate amount of COVID-related stress. They report concerns of contracting the virus, getting basic needs met, as well as access to healthcare and mental health care services. And there was one study that was published in early 2021, specifically in Maryland, looking at racial differences. And they found that the suicide mortality during COVID increased in African Americans while decreased in white residents in Maryland. So it'll be interesting to continue to monitor the data and explore racial differences in suicide during COVID as the data continue to come in. But this is something that we really need to be concerned about. because COVID is not affecting races and ethnicities in the same manner. Next slide. So Leo Scher put together this model of suicide in vulnerable populations with COVID-related stressors exacerbating pre-existing psychiatric disorders, as well as contributing to the development of new disorders. So the uncertainty, the social isolation, the economic problems associated with COVID-19 exacerbate symptoms, especially in people who are vulnerable, who have pre-existing psychiatric disorders, who do not have strong resiliency, who may reside in high COVID prevalence areas, as well as who may have a family member or friend who had died by COVID. And these contribute to the onset as well as some psychiatric disorders, including depression, anxiety, alcohol and other substance use disorders, PTSD, for example, which increase the risk for suicide. Next slide. So there's several other potential COVID-related risk factors that may contribute to the suicide rate increasing for the remainder of the pandemic and for several years following. Some of these include interpersonal conflicts, the surge of firearm sales that we've seen in the U.S., up to 80% in some months, and we know that firearms and access to lethal means increases the risk for suicide. So with all these new guns out, we're most likely going to see a increase in suicide due to having this access of means, as well as existential concerns, so fears of death, lack of meaning and purpose in life, barriers to mental health care. So where I work in Atlanta, a lot of our patients weren't able to travel into the clinic to receive their psychiatric medications, are still not able to come in due to COVID. So they haven't been receiving continued mental health care like they should. And this could increase suicide risk. Also, COVID-related illnesses and medical problems, adverse childhood experiences. So there's evidence that we've seen an uptick in childhood abuse and neglect and household dysfunction, which we know, years from now may increase the suicide risk in these kids that are experiencing these issues of ACEs. And then lastly, irresponsible media reporting. So the media not accurately reporting on suicide, but also the COVID response and all the political stuff. So it's really imperative for the media to really follow the guidelines for reporting suicides and as well as COVID responses. Next slide. Okay, so in order to address these mental health consequences and the potential increase, which I believe is most likely coming in suicide rates associated with COVID, we really need to take a comprehensive public health approach, including selective, indicated, and universal interventions. An example of a selective intervention is adapting to deliver mental health care in different ways, including digital modalities and telehealth. So if people aren't able to come in, we need to adapt. We need to have sessions with them virtually, prescribe virtually, meet their mental health care needs in a more adaptable way. In terms of indicated interventions, crisis helplines need to maintain and increase the volunteer workforce, offering more flexible ways of working and employing evidence-based interventions. And then lastly, some examples of universal interventions are ensuring those who face domestic violence have access to support and can leave a violent home, as well as, for example, firearm retailers need to be vigilant of encountering distressed individuals attempting to purchase firearms. So we really need to have this comprehensive approach of many different interventions on these three levels if we're going to stop the suicide rates that are most likely coming. Next slide. So in summary and conclusion here, COVID-19 is negatively affecting people's mental health worldwide. The early data suggests that suicide rate has decreased in COVID-19. However, there may be a delayed increase in suicide as a result of COVID-19, which again, the data is continuing to come in, but it's my belief that we will see this increase in the coming months and years with all of these stressors that COVID has brought on. There are a variety of proximal and distal contributing risk factors to suicide, many of which I've discussed today. We need to collect and monitor mental health, stressor, and suicide data. And in conjunction with this, we need to explore demographic characteristics, including race and ethnic differences that may be present in suicide rates during this COVID era. And then lastly, the comprehensive approach that I just talked about, including selective, indicated, and universal prevention strategies. Next slide. So I'll just leave you with this quote from the CEO of the American Psychological Association, Arthur Evans. He said, "Without addressing stress as part of a national recovery plan, we will be dealing with the mental health fallout from this pandemic for years to come." And I agree with him 100%. I really think we need to address all of these things that I've discussed to address mental health and decrease the suicide rates. And that's the end. Thank you.
Thank you so much. If you haven't put in, please put your questions in the Q&A panel. And Saha, can you start reading some of the questions, please?
Yes, we have a lot of great questions. So I'd just like to remind everyone, if we're not able to answer your question today, we will follow up with your registration email. So the first question, like the time frame for Alzheimer's disease, is it possible that the effect of COVID-19 may not be apparent for decades?
Professor Ikegawa, would you kindly answer this? Can you unmute? Oops.
So, please,
can you speak
repeat
up
again.
also?
Alzheimer's disease.
I think we can't hear you very well.
Can you hear me?
Can
you hear me?
Yeah, better.
Oh, really? The question is the COVID-19 and Alzheimer's disease relationship. Will you please?
Yeah, we'll show up 20, 30 years later. Is that the expectation? That's the question.
Okay. Maybe in the brain itself is a kind of some mysterious organ. And so the research field of Alzheimer's disease is struggling with finding some therapeutic disease now. And now people are focusing on some two pathway like amyloid and tau in the brain. So recently, some surrounding aspects like immunology or some metabolism is strongly affecting with the diseases. So I speculate that in a more younger generation complains of the COVID-19 inflammation in the brain, maybe some susceptible or possibility to develop Alzheimer's disease in the future, but nobody knows about. So it's an open question. Thank
Yeah.
you for the nice question.
Thank you. Next question.
Have the studies on the impact of COVID-19 on the brain included asymptomatic cases as well as the more severe cases?
Again, Professor Ikegawa, would you answer this?
Okay, the measure to find out what happened in humans' brain was nowadays using some imaging technology like a MRI. But sometimes MRI cannot find out what is going on, especially in the white matter. People who is studying the multiple sclerosis usually saying this phenomena like a normal appearing white matter.
No.
So now we are concerning this situation. So in case of the mild case of COVID, maybe we can take the MRI, but we cannot have some solid evidence from the MRI now. So targeting only some autopsy samples, we can know what happened in the human's brain. So it is a very nice question, but still we don't have any answer for it yet.
Yeah.
Thank you for the question.
Okay.
Thank you. Yeah, next please.
Is the increase in death due to diabetes related to worsening healthcare because of the pandemic?
Oh, that's a diabetes question. Dr. Charles, would you answer this?
There is no question that several chronic diseases, such as diabetes, have been neglected during the time, particularly last year, in the heights of COVID. However, the research has shown that there are increased susceptibilities to serious illness and death from COVID by virtue of the fact of the impairment on the resistance of the system and also just by the effect of the virus on weakened immune system in diabetes and other illnesses, and that some of the deaths have definitely been caused by the effect of the virus on the system and not necessarily by neglect of getting care. So it does contribute some, but it is not the answer to the situation in terms of death from COVID.
Thank you. Next question.
This is for Professor Lamas. Do you have any suggestions for how we can mobilize attention to mental health and basic public health infrastructure following the pandemic?
Yes, I mean, I think that we've seen it a bit already in terms of the reduction in stigma, which was already sort of happening pre-pandemic, but I think people are more accepting of, going and seeking mental health services, going to see a psychologist or see a psychiatrist. So I think for big public health awareness efforts that really emphasize that, if you are feeling depressed or anxious due to the pandemic, or you're experiencing these symptoms, it is perfectly normal to go seek out mental health services. And on a larger level, I think that is, and we're kind of seeing that already. But I think that is a good way to kind of mobilize. And then I mentioned this already, but in terms of the telehealth is really seeing a big boom. And I think that, and that's gonna be here to stay even when we hopefully return to normal.
Thank you. Next question, please.
I'm going to combine two similar questions. Are there different kinds of what we call brain fog? And is it possible that the increase in accidental deaths could be due to brain fog and other lingering symptoms of COVID-19?
Professor Ikegawa, would you answer this?
So-called brain fog is one way coming from the some inflammation, and one way from the some metabolic imbalance or the some vascular problem. So maybe very heterogeneous phenomena, I think. So with the increasing number of the evidence, maybe the content of the brain fog must be classified more definitely. But for the moment, the term brain fog is covering a very heterogeneous phenomena. So that's my answer.
Thank you. Next question, please.
I believe this is related to the quote Professor Lemus shared toward the end of his presentation. Are there any scientific theories as to the possible long-term mental health impacts of COVID-19, say in 10 to 20 years?
There in terms of theories, I don't know if they are, because this is so new. I mean, the only thing that we've experienced was the Spanish flu on this sort of level. There was SARS in 2003, and there's no theories that I know of that really explain these long-term effects. I did mention that pulling together hypothesis, but that really is more about short-term after a national crisis. I don't, in terms of long-term theories to explain mental health or suicide following something as catastrophic as COVID-19. I just don't know if we have I know we don't have the evidence to really come up with theories, but I'm sure there will be in the coming years. I mentioned things like substance abuse or childhood abuse, that we know that childhood abuse increases suicide 20, 30 years later, and we're going to see this increase in childhood abuse, and we're going to 20 years from now, how's that going to affect our children? Probably going to have a negative effect, and we're going to see suicide. So like I said, this is going to be with us for some time.
Thank you so much. Next question, please.
Is the loss of smell and taste permanent?
Professor Ikegawa, can you?
Yeah, that's a very, very, very nice question. I think it's reproducible because the olfactory system or the sense of smell is the only area in the adult brain who can regenerate. So some physicians are recommending to do the rehabilitation of the smelling after this viral infection. I think this is reproducible.
Excellent. Thank you. Next question.
Say more about the decrease in deaths by suicide during the pandemic.
Professor Lamis, please.
The decrease of deaths during, so like the immediately following?
I think so.
Yeah, I mean, the date. So it's somewhat of an open question. The data before the pandemic lagged behind 2 to 3 years. So we're really now scrambling to get any kind of data, complete data now. So that one, the U.S. study is they made estimates from the 6 months of 2020. So it's really difficult to say. However, given the data that we have, the first 6 months following the pandemic have shown that there is a somewhat of a decrease in suicide. And again, people, when this happened, people pulled together. They started connecting. They felt close to family. They started maybe realizing what was important, their family, and not working. And there was an immediate financial stress. And so, I mean, there's lots of hypotheses that, can explain this. But I really do feel like as the data continue to come in, and we have a more complete picture, we may not see this decrease. And I mentioned the deaths being potentially misclassified. We saw that 20,000 increase in unintentional deaths, which includes overdoses. Some of those could be suicides. So we're only talking, a decrease of 2,000 to 3,000. 2,000 to 3,000 of those overdose deaths that were classified as overdoses were actually suicides because they didn't classify them accurately. Then we're back up to the same number. Similarly, some of these COVID deaths may have been classified as suicide, so are misclassified. So once we kind of mine the data and really get a more full picture, hopefully we can answer some of these questions more accurately.
Can I step in? So are there any special efforts during the COVID to prevent the suicide? There's some kind of campaign, the worldwide or US wide, something like that happening? I think you're involved in some of that.
Yeah. So the International Association for Suicide Prevention was that the study that I discussed of the 21 countries, and the lead authors, Jane Purkis, and the chair of that group, which I'm involved, is David Gunnell in the UK. And it's a group of about 120 researchers from around the world that are, trying to get their country's data to really learn what's going on with suicide during this time. So yeah, there's an effort. It's the IASP, the International Collaborative. So we're all putting our heads together, combining data sources, and really trying to learn more with what we have available at this time.
Dr. Alchemist, is there anyone doing any prospective studies on possibly the increase in suicide with people with long COVID who just cannot get to a good recovery point, and as their psychiatric symptoms increase, lead towards suicide?
Yeah, Dr. Charles, that's an excellent question. And I did not include the long haulers or the people with long COVID in my presentation, but I see patients that are dealing with these symptoms, and they're staying with them for an extended amount of time, and it's causing depression, anxiety, things that they could do. They used to run, they used to bike, they used to exercise. Now they can't do any of those things. They can't even go on walks, some of them. So it's really affecting their mental health. So I can't say for certain, but I'm sure there's some studies going on that are going to follow long haulers and continue to monitor their mental health symptoms as well as their suicide risk, because they are a vulnerable group.
Thanks.
Thank you so much. Next question. One more.
Is there any notable research on vaccine recipients who have had prior non-flu related respiratory infections, which are not COVID-19?
That's a difficult question. Professor Ikegawa, can you try to answer this?
Yeah, it must be a very difficult question. Yeah, there are some questions on the vaccine's effect on the brain or some other systems. Still, we must carefully classify the vaccine mechanism and also some heterogeneity of the virus itself. So we should be careful about the vaccine effect as a prospective study.
Thank you so much. I think it's your timeout. Next slide, please. So those whose questions were not answered, we are happy to continue to answer. So please send us a question to this page. Please note that May 13th webinar, so that we can specifically answer to your questions. Next slide, please. And we will put up with captions for this event. And so pay attention to the notification, and those who attended will get the email from us. And June 23rd, we are going to talk about the COVID and disparities. So 2 biomedical ethics experts are going to come and discuss issue of disparities of the COVID and, unequal treatment for medical conditions, but focusing on COVID. So thank you so much for attending, and we look forward to meeting you virtually again next month. Thank you.